Head Start is a federally funded early childhood education program serving low-income families with children under the age of 5. One very important service offered through Head Start is mental health consultation. In our mental health consultation program, mental health consultants partner with teachers, staff, young children, and caregivers to offer classroom and home-based screening for child emotional and social concerns. We also offer consultation with teachers and staff on how to best promote social and emotional well-being. And often we provide referrals to community-based mental health providers for children and families who are in need of services outside of the classroom setting. Trauma exposure is common among populations served by Head Start, which includes low-income families and a lot of children with developmental disabilities. One recent study showed that 14.9% of enrolled families within Head Start had a court-substantiated case of maltreatment, and children and families served by Head Start experience maltreatment at very high rates, much higher than the rates of the general population. The Head Start program is designed to serve socioeconomically disadvantaged families, and federal regulations for program eligibility require that at least 90% of enrolled families have household incomes below the federal poverty lines. National prevalence data and theory on risk factors on child maltreatment indicate that the young children in low-income families are at increased risk for trauma exposure. So because of this, Head Start is one access point for reaching trauma-exposed youth at a very early age. When not addressed, trauma exposure and related symptoms often displayed by trauma-exposed youth, such as aggression, in preschool can continue into adolescence and adulthood. This places children at risk for a host of negative psychosocial outcomes across the lifespan. Some of these things can include poorer academic achievement, peer relationships, and social skills, and also higher levels of depression, externalizing behaviors, and a lot of other mental health concerns.
There are some approaches that have been identified for serving children in Head Start who are trauma exposed. However, limited research has identified specific methods for early identification and response to trauma that can be implemented in the context of standard mental health consultation services through Head Start. Given the potential for adverse outcomes, there's a great need to improve early identification and response to childhood trauma and related symptoms, particularly aggression, among Head Start youth. This presentation provides an illustration of approaches to embedding early identification and intervention for preschool children who may be experiencing or are suspected to have been exposed to trauma within the framework of the existing Head Start mental health consultation model.
First, we're going to share one story of a trauma-exposed family who received mental health consultation services through Head Start with some adaptations to the typical model. We changed some details in the story to make sure that the family can't be identified. This family is comprised of a mom and her 3.5-year-old daughter, who we're going to refer to as Annabelle. The family became connected with Head Start mental health consultation services through Annabelle's Head Start teacher. Head Start consultants had already established a relationship with the teacher over the course of the school year and made themselves available as a resource through providing teacher-child interaction therapy, or TCIT skills. Following that typical model of TCIT, consultants offered skills and coached teachers on behavior management, including praise, active ignoring, and special time. Annabelle's teacher had reached out to the mental health consultant for support in her classroom after noticing significant behavioral changes, and she explained that Annabelle had recently witnessed her father attempt to kill her mother. Fortunately, Annabelle and her mother had escaped with their lives after the incident, and her father was arrested. The child's teacher was concerned about recent changes in the child's behavior at school, including noticing that since witnessing the intimate partner violence, Annabelle didn't listen as well and didn't follow directions as well. Sometimes she rolled her eyes at the teachers or showed her middle finger. Sometimes she'd even bitten other children in the class. The teacher was also feeling really overwhelmed with coping with those trauma-related behaviors and also hearing about the difficult experiences that her child Annabelle had endured. The consultant helped the teacher to make a self-care plan, including taking teacher time during class when she has a teaching assistant to take a few minutes for her own self-care periodically throughout the day. The teacher explained feeling overwhelmed with so many behavioral difficulties to address in her classroom, which had really been increased since Annabelle's exposure to those recent traumatic experiences. The consultant worked with the teacher to make just one goal for all of the children in the class, like follow directions for the first time, and then when they meet that goal, having them place a sticker next to their name on a behavior chart. Building upon that typical Head Start model, while continuing to provide TCIT to the classroom, the consultant also called Annabelle's mother and gently explained that those changes in the child behavior at school since exposure to violence that were being reported by the teacher. The consultant also offered to provide some phone or video-based sessions to help enhance her ability as a caregiver to support herself and also support her child during this hard time. Annabelle's mom was interested in receiving services, so we proceeded to engage her in the child and adolescent trauma screen that looked for current traumatic stress symptoms and lifetime trauma exposure. Annabelle's mom indicated that she was experiencing some clinically significant symptoms. So as a first step, the consultant recommended a referral to trauma-focused therapy for the child and for her mom, and also helped them to join the waitlist at the local trauma therapy clinic. The consultant also recommended some one-on-one mental health consultation in that interim of connection to therapy. The consultant scheduled a time to meet with Annabelle's mother the following week and provided some psychoeducation about intrusive thoughts following trauma and why some of these behaviors often come up in relation to avoidance. Annabelle's mom reported her own emotional avoidance related to the trauma. For example, she talked about being unwilling to talk with Annabelle about the event. And when Annabelle would attempt to talk to her mom about the event, she'd say things like, "Oh, that didn't happen," or "It was an accident," regarding the intimate partner violence where the attempted murder had occurred. The consultant validated that difficult situation that mom was being tasked with, and then tried to align with her in her goal to help Annabelle to emotionally cope with that event. The consultant gently challenged Annabelle's mother's approach to avoiding talking about the event in entirety, that the incident didn't occur, and offered education to Annabelle's mom about ways that avoiding that discussion and diminishing those traumatic experiences actually can maintain and fuel PTSD symptoms. The consultant explained that in order to reduce or prevent traumatic stress from continuing long-term, it's important that Annabelle has a safe space to express her thoughts and her feelings about the violence with a caregiver. Annabelle's mom also expressed that Annabelle regularly asks about her mom's safety since seeing the event. So the consultant worked with Annabelle's mom to equip her with tools to approach that discussion around safety and safety planning with Annabelle. The consultant met with Annabelle and her mom together over video to help engage the family in a discussion around safety and safety planning. The consultant helped the kiddo's mom to communicate those primary messages she wanted to share about safety. First, Annabelle's mom validated to Annabelle, "This event occurred." Second, she expressed to Annabelle that it's understandable she felt worried for her safety after witnessing a frightening event. Third, she explained that it's mommy's job to keep kids safe, not the child's job. They discussed the changes in their lives in place to keep the child and her mommy safe, including knowing that her daddy's now in prison and cannot come out to hurt them, and that if daddy leaves the prison, that he'll live somewhere else. At the end of the meeting, Annabelle said that she was less worried about mommy and felt more certain that her mommy would be safe. Annabelle and her mom hugged after talking about these hard topics. The next week, when the consultant checked in with the family, they reported feeling more stabilized and not requiring further early crisis intervention. They stayed on the wait list for trauma services, and they were told that in the interim, should they need support, they can always contact Head Start mental health consultants for care. During this time, the consultant continued to work closely with the teacher and provided skills that could be applied in the classroom for the teacher to help Annabelle. So that included things like psychoeducation about traumatic stress responses, and tried to help normalize Annabelle's reaction to violence and equip that teacher with adequate skills to be able to respond. For example, the teacher was instructed to help Annabelle when she engages in those aggressive behaviors, first by understanding that that's a fight response, and then by helping to remind her that she's safe and guiding her through a grounding exercise to help manage that fight reaction. Over time, Annabelle's teacher reported noticing slow but sure behavioral improvements in Annabelle by supporting the family and the classroom in behavior management, safety planning, and trauma education.
Annabelle is one of many children with trauma exposure who we helped through Head Start. We conducted qualitative analyses on Head Start mental health consultant notes for 58 children with known trauma exposure, suspected trauma exposure, and social services involvement. We also included children identified by teachers as engaging in aggressive behaviors, which was used as an indicator of potential trauma exposure. We conducted a content analysis to identify strategies employed as part of the Head Start mental health consultation model. Children who displayed aggression without known trauma had a more traditional TKIT experience. These children spent 2/3 of their sessions on behavior management, and 15% were ultimately referred to outside mental health services. Children with known or suspected trauma exposure, like Annabelle, received tailored services in addition to TKIT. They spent only half of their session on behavior management, and 61% were referred to mental health services. To us, this suggests that adapting the model for trauma-exposed youth may be important. Our analyses helped us to identify 4 overarching strategies for adapting the existing Head Start model in order to better support and engage trauma-exposed families and address aggression and sexual behaviors in the classroom. First, teaching emotion identification and regulation skills. For children struggling to manage their emotions, consultants coach teachers and parents in using emotion identification and regulation skills. For example, one consultant played emotion charades with a child and her caregiver to help develop emotional awareness. Our second strategy was preparing teachers and other school personnel for difficult conversations with parents around mental health. Sometimes consultants struggle to connect with caregivers due to logistics or stigma around mental health services. In these situations, consultants leverage the relationship between parents and teachers or family advocates. Consultants provided school personnel with mental health education and coached them in using language that would align with parents' goals. For example, one consultant coached a family advocate with a positive pre-existing relationship with a child's mother and expressing the importance of therapy in helping her child become kindergarten ready. Consultants also sent resources like Pride Skill handouts and PCIT referral information to teachers to provide directly to families. Next, we provided education on boundaries and appropriate touches. Multiple children engaged in sexual behaviors per teacher report or during our observations in the classroom. In response, consultants incorporated related psychoeducation for teachers and caregivers. For example, the consultants provided guidance on sexual behaviors as potentially indicative of child sexual abuse and conveyed the importance of screening and assessment. For children in the classroom exhibiting sexual behaviors, consultants provide referrals for forensic assessment and coached teachers in providing reminders of appropriate touch expectations, as well as the use of labeled praise in the presence of appropriate touch. Finally, trauma screening, brief intervention, psychoeducation, and referral to treatment was embedded in the existing model. For children with known DSS involvement or trauma exposure, like Annabelle, consultants completed trauma screening and were referred for forensic testing or trauma-focused therapy as appropriate. Consultants provided psychoeducation about trauma to teachers and families. For example, one consultant working with a child who was recently placed in foster care provided psychoeducation to a teacher about common behaviors, emotions, and symptoms in young children following maltreatment and foster care placement, and helped to provide a trauma-informed lens for the child's behavioral difficulties. In addition, when safety concerns arose, consultants offered safety planning services. In one case, a child brought bullets to school, and consultants partnered with parents toward increasing safety in the home.
In our work with Head Start, we learned the following lessons for helping to better meet the needs of trauma-exposed Head Start youth. 1. Children in Head Start experience a number of individual and systemic difficulties that lead to increased risk for maltreatment, and there's a clear need for early interventions that address trauma exposure and related symptoms in this population. 2. Partnering with teachers in Head Start classrooms to identify children experiencing maltreatment and other trauma can help to connect families with early screening, safety planning, brief intervention, and referral to treatment for traumatic stress. And finally, expanding upon the existing TKIT model to incorporate components of emotion regulation, safety planning, and trauma-focused psychoeducation for teachers and caregivers are some adaptations that might improve the existing model to better meet the needs of trauma-exposed Head Start youth. Thank you so much for your time watching this presentation.